Good afternoon, Smile Mentor family. Matt Griffin here, the Smile Mentor. Today's video, we're going to be covering a really unique doctor, a great doctor out of Florida, Dr. Arun Garg. This was an unexpected part of our journey, but a very pleasant one. They're talking about God taking care of us on this. But Dr. Arun Garg is kind of a well-known name brand amongst dentists. Most dentists have either read some of his material, been to some of his courses. He's a teacher. He really is an expert on this subject. And so I wanted to give you guys a front row seat at our interview. He had, I think I've said it before in some of my other videos, but none of these questions are scripted. They don't have any clue what we're going to ask during it. And again, I'm not being paid for this and not paying them for it. So it really is as clean and fresh as you can get. And so he was gracious to open up his office there in Florida, down in the Miami area. And I think you're going to see why most dentists know about Arun Garg. So with that, enjoy this session. And for those that follow us, thank you. For those that have yet to, please do. And anybody looking to find out who we are, in the description below is about us. So I appreciate you guys and have a blessed day. Dr. Garg, I want to first and foremost say thank you for joining us on such last minute notice that as I've done research on you, it's a privilege to have you on our channel.
Hey, thank you so much.
Really appreciate that. Will you do me a favor? I've shared with you the heart and spirit behind why we're doing this documentary and try to get some of the tools in the hands of patients so that they have a good reference point. Can you tell me a little bit about yourself? I know you're not keen to brag on yourself, but could you do it a little bit? Tell me a little bit about your background and what makes you qualified.
I won't brag, but I'll tell you my background.
Okay.
Is after I did my residency at the University of Miami, I stayed there on the faculty.
Oh, wow.
Is the University of Miami School of Medicine for 18 years. And during that time, we invented a lot of procedures and published a lot of books and hundreds of articles and trained hundreds of residents that spent full-time years with us. And I left there about 5 years ago and went into private practice right here in Miami. And then have continued to write books and write articles and develop new techniques and stay at the cutting edge of things.
Yeah, and one of, if I read something correct, part one of your degrees was in engineering?
It was. My undergrad degree is in engineering from the University of Florida. Absolutely.
Wow. Tell me about that. It was chemical engineering?
It was chemical engineering. My dad is a physician and he's a kidney specialist. And he said, don't do medicine. You're going to work too hard. Go become an engineer. Get an 8-to-5 job Monday through Friday.
Okay.
And so I did that. And then I realized when I graduated that really wasn't my passion. And so I kind of did dental on a lark, as my closest friend in undergraduate was applying to go to dental school. I actually didn't know what it was. I knew engineering from my background. I knew medicine from my dad and his friend's background.
Sure.
And I sat for the DATs to keep him company. I'm a good test taker, and I did well and ended up applying and going. And then from there went on to do surgery and then is subspecializing in dental implants. And that's how it occurred.
Did you have anybody else in dental school that had a chemical engineering?
Not in my school, not in my school. But as I've traveled around, I have occasionally met folks with this unique background. And so, of course, we have instant rapport and instant communication. What I found is about chemical engineering is it teaches you to think. And I found out in med school, it teaches you to memorize. And so what happens is, I think that's what has allowed me the ability to be able to be creative and think up new and innovative surgical techniques and procedures is that background. The one that was thinking, not simply the memorization, is background.
Speak to me on the business side. Most clinicians, right. I'm going to be real candid with you. That's what's kept us in business is, I'm the business piece, they're the clinical piece, because they don't have very much entrepreneurial or business. But you seem to have that. I've seen kind of what you built. Right. I've seen, I've got an eye for it, just like you have an eye for someone's smile, right? You're going to be able to tell real quickly. their midline and those type of things. But on the business side, where did you get your training on that?
Well, I have to tell you, 18 years at the university was zero business.
Yeah.
The hirings and firings were done by the HR department and running the budgets and such. And I had no idea of what costs were, expenses were, and et cetera. I left the university and went into private practice. And the first 4 months, we did fabulous. My university salary for 18 years was $42,000 a year. And I was not allowed to moonlight in a clinical practice. All clinical dollars belong to the university. Any patents I developed belonged to the university. I was not allowed to own a gas station or a bookstore or anything else on the side. And so I didn't even have time. I was there on Monday morning from 7 in the morning till about 10 o'clock at night, 6 days a week at least. So I was putting 80, 100 hours a week. So I didn't even have time to moonlight. And I didn't live on $42,000 a year because, of course, $12,000 went to Uncle Sam. So I lived on about $30,000 a year for 18 years.
Wow.
And I left the university and opened a private practice. While I was there, there was a community hospital where patients got everything for free. And that's where I could try out new procedures and develop things. And there's a private hospital across the street where they paid normal fees. And on the normal fee side, by the time I left, my clinical collections was about $4.5 million a year. It's not, again, to brag about what I made, because if you think about it, 4.5 million, 10% is 450,000, 1% is 45,000. I was getting paid 42,000. I was making less than 1% of my collections.
Wow.
But when I went into private practice, I was able to generate the same amount. So I took $1 million loan to build out a fabulous office, and is my first month is we did $400,000 in collections.
First month.
First month. Because there was a lot of patients waiting for me. They did not want to go to a hospital setting. They did not want to park in a parking lot, walk a half hour through the parking lot, go up elevator and see cancer patients and radiation patients, et cetera, to get their implants done. They wanted a private practice setting. So they've been waiting for me, and so they all came as soon as I was in a private practice as setting. And so if you do the math on that, that's $100,000 a week. I mean, literally, I was making in a week what more than I was making in a year before. And he said there's overhead, but even with 60% overhead, I was making roughly in a week what I made in a year. Yeah. You know, I get his email ads from Grant Cardone all the time about 10X in your life. And I'm living proof that I was able to 52X my life is there. And that occurred for about 4 months. And I thought, wow, I'm going to pay these loans off early. And because my lifestyle was still the same as the college professor lifestyle. And then the practice crashed. It crashed because I didn't understand about marketing. I didn't understand about talking to patients. I was still doing what I was doing there. And it was okay because there was a group of patients that were just waiting for me. They're friends, and there's my parents' friends, and et cetera. So I didn't have to give them a half-hour consult. I would do what I did at the hospital. I would walk in, stare at the x-ray with my back to them, explain things for about 3 minutes, and walk out the door and let my residents schedule them if they want to schedule or not. But in a private practice setting, patients wanted to find out is more than 3 minutes information with my back to them staring at the x-ray. Because they want to know that I'm treating a human being, not an x-ray. And
Great
so
point.
Once I ran out of my parents' friends who already knew me as a human being, but other folks nobody was accepting treatment. And here I was doing amazing clinical work, but without the ability to explain that and communicate the amazing clinical work we do and the life-changing work that we do. If I'm not communicating, it is not their obligation to read my mind. And that's what I realized, is the first group, the ones that came, my parents' friends and my friends, they didn't need to read my mind. They knew my mind, they knew my heart. But the second group, the strangers, they didn't know my mind and heart, and here I was expecting them to read it. And what I had to do is, I did what I've always told folks to do. You know, I write books, I have residents, I do courses. And I said, wow, I'm always the guy that's teaching, but if there's something I don't know, I have to become the student. And so I signed up for literally every course on these types of things, on communication, on how to talk to a human instead of an x-ray, and how to talk for 20 minutes, 30 minutes, whatever they need, instead of whatever I need to move on to the next room. And those things were expensive. And yes, I made is nice revenue in the first 4 months. But then the next 4 months when things crashed, I lost it all.
Yeah.
Now it wasn't a matter of being able to pay the loans up early. Now it's a matter of just trying to pay the bills.
That's right.
And I take another loan to take the CE courses. And I took them and I studied and worked hard. And what I found is it's interesting is going down happened like this. Once I ran out of patients that knew me, is climbing back up doesn't happen overnight. That was a long road. That was years. And then is to be able to is talk to them and be able to show them the things that we can do.
You know, I appreciate you sharing that because you did it out of necessity to say, but I guess part of it's that engineering background of you're trying to find a solution.
Solution, exactly.
You know, you gotta say, wait a second, something is. How do I fix this? And if I don't have the tools and resources, I need to know where to go get them.
Right.
Right. And so I applaud you for pushing through, and I've seen some of what you've built already, and it's quite impressive. So you did a good job at doing that. What would you say the greatest out of all the lessons you learned from transitioning from X-ray to personal experience? What was the biggest lesson in all that you learned about the personal experience?
Well, there's a couple of things.
Okay.
Is number one, I realized that it's a good thing that I crashed. It's a good thing that I crashed, and is desperation time. Had I only crashed somewhat and been mediocre, it's easy a lot of times. Not my personality, but maybe I would have just kind of wallowed in mediocrity. Okay. Again, I don't think that's my personality, but I think maybe that would have happened. I think it happens to a lot of people. Whereas when it's rock bottom, there's no wallowing in that. I had to do something, and so it really forced me to take action. And then the second thing is what I learned is because there was times when I said I should go get this training, or I should move on to this project, or I should, and the shoulds turn into 6 months, a year, 2 years later, and now what I've realized is. I don't have regrets about anything I've done. I've loved all the things I've done in my life. Yeah. But the times that I was saying I should, that's the only times I regret. Because when I'm mentally not quite there, I feel like for myself or anyone around me, my advice is if you're thinking about doing it, okay, do it. Okay, if you're thinking about doing it, instead of spending 6 months, a year, 2 years, just thinking about it, that's the only time you're going to regret. Not the things before, not the things after, but the time you're thinking about it and just kind of I'm not sure.
What about the patient side? So you spent 18 years, you said, correct?
Yes.
At the hospital and
as a faculty.
As a faculty.
Yes. Full time.
And so in that faculty position, again, you had residents and that type of stuff that you would read an X-ray, you would diagnose, you would say, here's what we're going to do, and then nice to meet you, and you're out the room, right?
If you want to schedule with one of my residents, and I'd walk out. I had a long white jacket, I had a bunch of badges hanging here, and that was the university name, my badges, my long white coat, that was the credibility factor. Yeah. And I had a lot of famous patients. I had lots of politicians from Central and South America, lots of folks from the music industry because the handlers had done the homework for them. But these folks, the handlers had done the work for them and said, this is the guy to go to.
That's a great point.
So they weren't depending on building a communications from me. The handler told them, this is the guy, go meet him, and then he's going to schedule you. So all they were there for really is to make sure that I don't look or act like Quasimodo.
Right.
And short of that, they were pre-sold.
Yeah.
But when I realized that here in private practice, they're not pre-sold. They're there more than just to make sure he's not Quasimodo. They're making sure that this is someone that I feel comfortable with. This is the guy that's going to cut my face.
That's it.
Okay? And do I feel comfortable with this guy is on a personal level and on a skills level is to do that. And the follow-up level and communication is going to be accessible to me. Yeah. To this day, every single surgical patient gets my personal cell number. It is not a answering service. It is the office number.
Good move.
Every single one.
Good move.
And I find the more folks I give it to, less. And do I get none calls? No. And I'm not doing it as any type of maneuver. I do it from the heart. I get maybe one call a year. And I think I get less calls because they know they have instant access instead of going through a service.
Yeah, that they don't have to try to chase you down and
Yes.
where is he hiding and
Right.
all that kind of type of stuff.
Because when you have to go through a service, you start saying, you feel something, go, let me start calling because the service might take 6 hours, 10 hours, 12 hours. I don't know. So I better start calling sooner. Whereas I get a phone call only if it's something.
Right.
Is they know they have instant access.
Right. Good move on that.
Thanks.
Good move. Tell me about the patient. What have you learned about the patient in this? So you've learned that they don't, especially on the private side, that they need more reassurance and education. What have you learned about the patient's personality that differs from the hospital setting versus the private practice setting?
You know, patients, like everything else, come in all sizes and shapes and colors and such. But if we're talking about sort of is extensive needs, is patients, is for extensive needs, it seems to me that the two most important things, the two most is commonly seen things why they've gotten to this stage of needing extensive work is usually been money or fear. Okay? It can be, well, I didn't have time, but a lot of it is money and or fear. And so those are the things we've got to address off the bat. Is we got to address is both of those. If it's a money issue, we've got to address that. Is can we and should we be giving them 24-month financing, 36-month financing at 0% interest? We can and we should and we do is offer that. If it is a fear issue, should we offer sedation for them? Should we offer things in as few visits as possible? Should we offer things as quickly as possible? I will give a different example for a single implant. Is I design the case, I use a computer guide, it is literally in our office a 3-minute procedure. I walk in, place the implant, close it up 3 minutes. And I tell the patient that it'll be 3 minutes. If you put an iPod in, one song will be done. If it takes me 4 minutes, I'm having a bad day. And if 5 minutes is 2 songs, you know I'm having a really, really bad day. Now,
5 minutes. Really? Help me out with this. How do you, so they're already extracted?
I'm saying for a single implant.
Oh, right. So is the tooth already gone?
Right. Tooth is already gone.
Okay.
Okay. I put the guide in. I do a flapless surgery, 1 burr. Okay. Put the implant in. Take the guide out. We're done.
Wow.
Yes.
It's impressive. It's impressive.
Okay. So thereby so I say, Ms. Jones, if you're getting 3 implants done, it will be 9 minutes, or if I'm having a bad day, 12 minutes. Okay. In essence, I'm doing it endoscopically. You know, instead of a big surgery on your shoulder or on your knee like the athletes get, they go through a small opening. That's what I do. I do endoscopic implant placement. No incision, no sutures. I make a small opening, put the implant in, and no blood there. So if we can address the money issue through financing, no interest, if we can address the fear issue, that's so comforting for these folks that have these kinds of needs. Yeah.
Huge, because you know this is something that having gone through this on the family side personally, like I mentioned to you, I'd gone out of the country to try to get some implant work done, not because I didn't have money. That's back when I was in the oil and gas business and things were great, but it was well, do I want to invest all that extra? And I learned the hard way. You know, sometimes you cut corners and you got to redo it again and go through all that. So I'm not always the biggest, you know, you do get what you pay for, especially in this world. But the financing piece of it, I'm really glad you attack that because, you know, to think that, you know, a full mouth is significant price of a car, right?
For anyone.
That's right.
For anyone, for everyone.
That's right. That's right. And so having that option, you know, if I only knew I could go buy a new Mercedes and only have to pay cash, versus, okay, well, pay it off a little bit as I make money and that type of stuff. So I'm glad. And you guys do 0% financing on some of the. That's great. Yeah. What have you seen? I want to before I go into some of what I've found out about you on the training other clinicians, which I think is huge. Talk to me about your patient consultations. One of the things that we had hoped in this documentary is to empower that patient to know whether they're in California, Washington, here in Florida, the Miami area, or anywhere in this country or in the world, as a matter of fact, what questions do they need to ask when they're sitting in that chair, interviewing, because the doctor works for them.
Absolutely.
Right?
Absolutely.
Interviewing the doctor. What would be some of the questions you would recommend a patient to ask in that setting?
That's a great question. And I will tell you, the first question I ask patients when they come in is, where else have you been? Mm-hmm. I always start with that. So I also know have they been at 3 places before, 4 places before, no places before? And sometimes they almost act like guilty to give a response, like, oh, well, I've actually been to 3 other places. And I tell them, of course, I would expect that. This is a big decision. And I would expect you've gone to numerous places and interviewed them. Okay? And I put their mind at ease about that. That's normal. That is what I expect. I joke with them, of course, and then say, this is the final place you need to go. Okay? So what do they need to know? Is the biggest thing is they got to know the credentials. They got to know, is this person done 1,000 of these procedures, 100 of these procedures, none of these procedures? Where is he on this?
On the experience level, yeah.
Yes. So they've got to know those credentials. Mm-hmm. How experienced is he on this? Then they've got to know we already talked about, is financial options, to see if this is something that is going to be doable for them. If it is fear is one of the issues. They got to know about what kind of sedation is available or not available, or how quick it's going to be, or how slow it's going to be. They got to know about the team.
Huge.
Because that makes a huge difference. You haven't been a patient, you know that.
Yes.
Is good nurses, good assistants compared to not good nurses. It makes a huge difference. Good is welcoming is reception, not welcoming reception. A good laboratory that can get things done on time or not get things done on time is about the team. Yeah. And it's different to simply ask the question, how good is your team? Great. How good is this? Great. To ask for some examples. So it's important for patients to ask those types of things. How long does the lab take? Where is the lab? What kind of lab do you use? Can I meet your hygienist? Can I meet the front desk? Of course, they've already met. To get to meet the whole team.
That's a great point. And, the team aspect of it really is underrated by most patients, because they think it's just the doctor. Now, the doctor is the captain of the team, yes. But it's the team that makes the victory.
Huge difference.
And I've seen...
And as a patient, you know that.
Yeah.
Yes.
And in the roles we've been in, dealing with a lot of different clinics, I've actually had to not take on services for clinics, because I've noticed, look, I don't want our name associated with this, because the doctor might be pretty good, but going back to that businessman, which really is the assembling of the team, is a big part of it. And so...
And leadership skills.
Yes, absolutely. Yes. And what you attract. And so how would you as a patient, not having the knowledge I've had in the past, just a patient that's normally coming to you, how can they really know what kind of team? Because you brought up a good point. Well, how's your team? Good. What doctor is going to go mediocre, right? I mean, so how would you really sift that out if you're a patient?
Honestly, I don't know a good way, because my dad fell recently about a year ago, needed some neurosurgery, so I was in the opposite role, not myself as a patient, but helping my dad go through that. So finding the surgeon it wasn't an emergency surgery, so he had time. So I went with him, and I was in that role, because it's neurosurgery on the brain, on my dad. I want the best in the world is for him. But do I fly him to another city, or is the best right there? Or do I want the best in his town? And interviewing them. And I don't have resumes of the staff. So what am I looking for? I'm looking for my telltale signs of clinical competence. When they're taking his blood pressure, I'm looking for telltale signs of their friendliness, of their communication abilities. That's what I'm doing. For the surgeon, I did look up his credentials, and then I asked other people about him as well. as other physicians as at the hospital. So it would be asking as other folks, as it would be looking up as much as you can about his credentials of the doctor. And with the team members, really for me, it was observing telltale signs, because if they're excellent about each detail, if they're excellent on how to put the blood pressure cuff on, I'm assuming they're going to be excellent on the post-op care. If they're sloppy putting the blood pressure cuff on, I'm assuming they're going to be sloppy with post-op care. Not always a correlation, but oftentimes those that are pickety sneaky on this thing are going to be on other things. Those that are sloppy on one thing may be on other things.
Yeah.
And so I was looking for those kinds of telltale signs.
You know, and the confidence level, you know, you can pick up on that as a patient. Does that assistant look like just a new hire, that they are so timid and scared to do anything? How's their interaction with the doctor? You know, that's a big piece of it. Yes. You know, some of the doctors, actually the doctor who did my surgery, you know, his assistants, he doesn't even have to talk during it, because they've got that communication that's even nonverbal and respect. And so do they have a respect for the doctor, and does the doctor have a respect for them? Can they pick up on that? I think that's an important piece.
That's excellent.
And I think that, you know, you touched on something else that, you know, I when it was my mom's turn, before I did, even though I had some relationships and I knew some clinicians, right? I was just getting into really growing our business, working with other implant doctors. I decided, you know, I want to go see and interview the big boys. You know, and so in Dallas we have a handful. So I went to Clear Choice. Yes. You know, I want to see what's the hype about. Exactly. I went to Arch Point. I went to go meet Dr. Mike Golpa at his new practice there, and so and I went through all the consultations, and I got to see some of this, and I love the fact that some of them, when they would find out you've been to other consultations, would seem offended, which the patient, you brought up a great point, that this is a life-changing event, and rarely do you find that right when the first time. Right. Sometimes you do. We interviewed somebody in Atlanta that did, but it's pretty rare, so don't feel embarrassed if you're a patient, and I'm so grateful as you as a clinician don't make them feel that way.
No, it's like buying a house. I mean, you may circle back to the first one you saw, but you got to see 10 others.
Yeah.
Buying a car, you go to several places. You may circle back to the first one.
Right.
But it doesn't mean you're always going to. And it's the same thing with important is work like this, is second, third, fourth opinions. Absolutely.
Yeah. You know, I think that. I want to move a little bit to the clinician training side that you do. You train other doctors in this field. Yes. You also give some unique opportunities for doctors to not only hear you, but hear from a lot of the other top guys in the industry. Talk to me about today's new dental grad. What's out there? Talk to me about what you're seeing that's coming up, because you train a lot of, I know seasoned guys, but you also train some new guys, I'm guessing. Of course. So talk to me about what this next generation looks like.
Is as much schooling as is given in dentistry or medicine, et cetera, and you go 4 years of undergraduate, 4 years of postgraduate, 8 years of college, it is still not enough to learn all the things in dental or in medical. Mm-hmm. And so what happens, there's a need to keep on learning. And so what happens, graduates can get the basics. You do some fillings to graduate. You do a couple crowns to graduate. And so is on implants, almost nothing, for example. On bone grafting, absolutely nothing. Yeah. On extracting third molars, nothing. And so there's a need for that. And even on things that they've learned, fillings. You know, in the last 20 years, we're now up to 8th generation of bonding agents for the white filling. So you take an average 8th generation in 20 years, that means about every 2.5 years a newer bonding agent has come along, different materials. And if they're not going to go back to dental school, you got to learn that things through continuing education. Yeah. So there's mandatory legal requirements that every doctor, every dentist has to take a certain amount of CE credits every 2 years to renew their license. But beyond that, just to stay current with the times, to stay current for the practice and their patients and themselves, they have to do that. And so this has been going on forever. It has always been something that is new graduates is needed to take these things. And now it's a little tougher for them because now they're graduating with tremendous debt. So historically they had debt, but the debt wasn't at the same level. It was $30,000, $40,000, $50,000. Now the debt is $300,000, $400,000, $500,000, $600,000. So now what happens, they get this tremendous debt, and yet they need this education. And so that's what I see as different. They've always needed it, but now it's a lot tougher for them because they got this tremendous debt.
What DMD versus DDS?
The same.
Why is there different? I mean,
the same is it has historically been DDS, and then Harvard University. They like to do a lot of cutting edge types of things. They made dental school there 5 years, for example, whereas the rest of the country are 4 years. That did not catch on. The other dental schools did not replicate that. Is from what you and I just talked about, maybe that would be a good thing if they replicated that, because there's so much to learn, but they haven't. They decided that because DDS, dental surgery, they decided it's more of a, in essence, like a medicine topic. Doctorate of dental medicine as opposed to doctorate of medicine. And so they thought that is a more appropriate degree. And so they said, that's what we're going to award. And that about half the universities in the country adopted. So about half adopted DMD, about half adopted DDS. Most state licensing boards allow you to use either one, irrespective of what you were actually awarded. Most people, for sentimental reasons, use the one that they're awarded. I was awarded DMD, I use DMD. It looks awkward to me if someone inadvertently puts DDS on there. But it is considered equivalent. And in fact, most licensing boards allow you to use either one interchangeably.
How important is it to have a specialist do this procedure versus a non-specialist?
What happens for certain things, there's a recognized specialty. Orthodontics, braces, recognized specialist versus general dentist. Endodontics, root canal, recognized specialist versus general practitioner. For implants, there's no recognized specialty.
Right.
And that's why so many folks will do it. So oral maxillofacial surgeons, is hospital dentists, is periodontists. Those are the common folks that will do it. Is some endodontists, and of course general practitioners. So it's important to find someone who has done some training beyond dental school, formal training. Is not simply CE. If you can get someone who has formal training, is hospital dentistry, GPR residency, is oral maxillofacial surgery residency, periodontal residency. Some prosthodontists are doing the surgical side. Is that residency, some type of residency training.
Residency training. And so the best way for them to ask if they're in, have you done any, what additional training have you taken?
That would be the great question. What residency training have you had?
What residency training?
Residency and or fellowship training, yes.
And so if they said, well, I've done this course, I've done that, then you got to kind of go versus.
Then it's not full-time, then it's not years, then it's days and not full-time.
Yeah. Which would maybe have you pause a little more?
Absolutely.
Okay. Do you see any of the patients that you have worked on, how many cases have you had to fix other people's work?
Now we're talking on this type of tilted implants or just in general?
You know what? Let's start with in general.
In general, we probably do one fix a week.
Okay.
Or I personally do, is about one a week. But that may or may not mean that there's so many things out there to fix. It may just mean that we're the ones that those things get sent to.
Sure.
Okay. When I was at the university, we probably did one every other day.
Wow.
Because folks said, okay, this is maybe fixable, maybe not fixable. I don't want to be involved. Send it to the guys at the university. So we used to get a lot of that. And we actually got excited about it because it wasn't as boring cases. I was getting my $42,000 a year, whether to do boring cases or exciting cases. I would much rather do exciting cases.
Right.
And it gave me something to publish. And the more I published, the more promotions I got. Not more money, but more promotions and more raises. And it gave me something to lecture about. So there's a lot of neat stuff that came out of doing these challenging fixes.
Yeah.
In private practice, not so much. I'm still publishing, but not as much. I'm not as interested. is I'm publishing for the fun of it and to share the information, but there's no promotions attached to it.
You don't get paid any more, any less. You don't get any. Yeah. So it's
but it's still one a week.
But you know what's unique, and I'm going to switch for a minute, and I'm going to brag on you for a minute. You showed me a book while we were setting up and getting ready. Dan, would you do me a favor and bring me over that book for me, please? The Full Arch Implant Rehabilitation, and this is authored by you.
Yes.
And it was published by Clinicians.
Yes. They're considered the top publisher in the dental industry.
Okay. Yes. And I have yet to see, you know, I mentioned before, I've been in another country with 2,000 dentists getting continuing education, and yet the education side on this has really been lacking.
It has.
Would you agree with that statement?
Absolutely.
Talk to me about that.
Yeah. You know, it's in any other aspect of dentistry, third molars, there's 20 different books. On gum surgery, there's 40 different textbooks out there. On crowns and bridges, 20 different books. And there was no book, no resource for dentists or specialists on this procedure.
Yeah.
And there's guys that were the innovators on this procedure 20 years ago when these types of procedures came about. And you just don't see any current textbooks. And so we started putting things together and collecting pictures and writing things down as protocols for our teams. And those protocols then evolved. We said, wow, there's such a missing piece here. I spoke to my friends at Quintessence. I said, yes, there's a huge need. And they said they have tried to commission books on this topic numerous times before, and nothing has come of it. And I said, well, we've got great things that we've put together for our team, and that could easily be converted as modified to put this book together. And that was the genesis of this book. This is 2019 is publication. It's surprising to me that there aren't 10 books out there already by 2019 on this.
Because this has been around for a little while. I mean, I know it's relatively new in some senses.
But it's been around.
But it's been around for a while. And so, you know, as a patient, I'm both excited that you took on this project. I am so grateful that you are taking time to give protocols, because working with some of the other doctors, you know, protocols are key.
Absolutely.
You have to have those.
Yes, you see bestseller lists recently. The Checklist Manifesto is on the bestseller list. I mean, that's how NASA launches a rocket.
Yeah. Is
with checklists.
Yeah.
With things step by step by step by step.
And we went over this for, I don't know, about 15 minutes while I was here, and you showed me that you kind of built a recipe book for this, for these doctors. And so have you, anybody who wants to order it, tough luck right now because it's on back order, but more should be coming out, right?
Yeah, the first printing, it looks like it's sold out on Amazon. We just Googled it just now, it's sold out. I'm sure within a couple of weeks, they'll start shipping again.
Yeah. I was impressed in reading some of this because, again, you know, like I said, how many marketing guys know what a periodontal ligament is and how important that is to, you know what I mean? And so I have a deep appreciation for this. And past the whole knowledge piece, my mom is a big inspiration for me doing this, because when I was in the process of going through those consultations with her, when I was going through the process of, you know, we have been, you know, you talked about the different groups of patients. We're in that patient that have had some clinicians in our past that have not done the work they should have done, and that's been validated, and that gets frustrating because sometimes your trust level really goes down in something like this. Of course. And so, you know, that being the spirit behind this, to see that there are at least some good guys out there, and that's what I've told our public out there, that, you know, I know I've beat up on the dentist in the past, but there are good ones out there, and I'm grateful for those that have come together in this project. What would you say the biggest success in your dental career has been?
Patience.
However you want to
well,
answer it.
it sounds like you're asking about patients. I will tell you, when I first went into private practice, a nice lady came in, and she was a housewife. She was in her his late 20s, had 2 young kids, and her husband passed away unexpectedly in a car accident with no life insurance. And so she started grooming dogs. She was from another country, had lost all her teeth, and started grooming dogs, making minimum wage, and raising her 2 kids. And now, fast forward 20 years later, her kids are both grown up, and she hasn't dated for 20 years. Since her 20s, she's in her 40s or 50s, hasn't dated since then, and came to see me and said, I want to get my teeth done. I would like my kids when we start dating again. They're grown up and out of the house. And as we gave her a set of teeth, as she went on, as she met a guy, wonderful life. The 2 kids are both successful attorneys now. They called in and said, okay, they each gave their credit card numbers, said put half of mom's care on each of our credit cards. She, on grooming the dogs, is raised us to be successful attorneys now. We want to give back to her. I joked with her. I said, we'll take care of your teeth and find you the guy.
Has she found the guy?
She absolutely did.
She did?
Absolutely did.
Oh my gosh.
That is life-changing. That is not doing a cavity for someone. That is not pulling a tooth for someone.
Amen.
That is changing her life.
You've been real candid with me on how you had to learn how important marketing is the hard way.
Yeah.
What would you say? So I appreciate your candor. If you would you mind sharing with us what you would consider your biggest failure?
I think is the places where I delayed things. You know, I had a phenomenal career at the university. I loved every minute of it. Where I delayed, I said, probably a year or 2 earlier was mentally thinking of opening private practice. And there I wasn't focusing on a private practice. I wasn't really focusing there. That delay is wherever I've delayed things. If I'm thinking of building a new project or a new office, and now I have a number of offices. I've got 4 offices in the Miami area. I have 1 in Phoenix, Arizona. I have 2 in Dominican Republic. So the delays where I start thinking about it and it takes me 3 years, like, wow, I lost 3 years of my life, is waiting for that. So those have been my biggest regrets, is wherever I've delayed things.
Yeah. Last question or last piece. Will you mind sharing with our group the story about your mom? You know, you talked about how your mom was at a stage where she was going to have some work done and what you originally thought. Will you kind of share that story with me again?
Sure. My parents live in Gainesville, Florida. That's where I was born and raised. And that's a small college town. Go Gators. And I'm here in Miami now. And now she needed some almost kind of routine dentistry. And so she came down, drove down, and it's a long drive, 6.5 hours for them each way. And it turned out that it's not routine, that some of these teeth that she thought were routine, they really need to start coming out and such. So
we can relate to that.
Yeah, so we said, okay, we'll take them out, and we'll socket preserve. I'll do bilateral sinus lifts. I'll do bone grafting. That's what my earlier books, that's what they've been on, bone grafting. That's what my seminars and teachings and courses and lectures have been on. And that's what my expertise is on. That's what I'm known for. So I said, okay, we're going to do the bone grafts, and then after that, we'll put in the implants. And we'll put in 8 or 10 implants, and maybe 12, and have individual crowns or bridges. And we're going to perform this at the highest level, the level that I know I'm capable of, and the level I would offer to someone with unlimited budget is subsequent to that. So we planned it all out, and we're going to get started with this. And subsequent to that, a good friend of hers came down, and that good friend, I spoke to them, and I said, well, what would be easy for you is to take out the 5 remaining teeth and doing the tilted implants, the full arch implant rehabilitation, as we call it, concept, and giving an immediate prosthesis that day that's screwed in, and then you come back down after that, or in Gainesville you get done a definitive prosthesis 6 months later. So it's essentially one trip with me, or possibly several more, but essentially one trip. And she was here for the consult. She said, you know what, if you can squeeze me in, I'll get it done while I'm down here. I said, great. Okay. And she came on Monday. I said, if you don't mind, I do need a couple of days just to free up my schedule, but I'll get you in for Friday afternoon. Same trip, took out the 5 teeth, put in the implants, put in a prosthesis, screwed in. she went back better than she had come.
Right.
Mom came down. We took out her bad teeth. She had more than 5. She had a lot more. Took all those out, psychopreserved, and gave her a denture. That's a classic way of doing it.
Sure.
Gave her a denture. They both go to Gainesville, and my mom's comparing notes. Said, wait a minute, I take mine out every night. I sleep here, and my teeth sleep here. And you sleep here, and your teeth sleep there.
Yeah.
And it's my son. My mom was so confused about that.
Wow.
And I tried to explain to her that, Mom, I'm trying to give you is at this level. In her mind, what her friend had was at that level. One visit, and she was done.
Was actually at the better level.
Yes.
Because it was more convenient.
Yes.
And okay, so.
Okay. And my mom she's not a fearful patient. It wasn't multiple procedures from that perspective. Although for some of them, the same reason, it could be one procedure as opposed to multiple surgeries.
Yeah.
Okay. But in her case, one procedure for convenience factor.
Yeah.
And she asked me. And so we switched gears. And I said, okay, we'll do this. Next time you come down I'll give you the tilted implants. We'll put the prosthesis. And that's what she's getting. And she's got the transitional in now. The definitive from Pinas Adar in Atlanta has already been shipped down. It's in my office now. She just needs one trip down, and the definitive will be screwed in the next several weeks. For her.
That's awesome.
So it's 2 trips.
I need to let him know when I talk to him next, because I talked to him a couple days ago, Bernard, to say, that's cool. I love how these dots connect. So your mom, having access to you, which is a very high-level clinician, could have had what some people might say is the Rolls Royce, individuals, all that kind of good stuff.
And that was her treatment plan.
Yeah, and yet then she saw what her friend went through and what you were able to do for her friend and said, I want that.
Yeah.
And you gave her that. Yeah. And she's happy.
It is more happy. And what I realize is, and realize prior to that also, but we have to realize that is we can't apply our biases from the patient's perspective. We look at is from their perspective. We've always got to be treating them and their particular circumstances, not their mouth, but the human being. And the human being attached to that mouth is someone that doesn't want to drive 6.5 hours each way multiple times, would like to do it in as few visits as possible. That's the human being attached to that mouth.
Yeah. I know I said last thing, but I've got one more last thing. Anybody out there who knows anything about stem cells and what your own body can do from a healing standpoint, you might have heard about PRP, platelet-rich plasma.
Yes.
Talk to me about that.
In the early 90s, Bob Marks at the University of Miami and we were doing a lot of bone grafts. And what we need to do with our bone grafts is stabilize them, make them sticky. Because a lot of times we couldn't get immobilization of the bone graft in large defects.
What do you mean? When you say the immobilization, they would move instead of stay in place?
Yeah, for example, if you put a bone graft into a socket, you have all the walls of an extraction socket to hold that bone in there. But if you're trying to build up a ridge, it's just a bunch of gum tissue holding that bone in there. And so in Europe, what was available was fibrin glue. They took from the tissue bank blood, they divided through a centrifuge, the red blood cells, the platelets, the fibrin, that's what makes the scab sticky, the serum, okay? And they took the fibrin, essentially freeze-dried it, and that was available. So surgeons in Europe, if they had an incision, they could, instead of suturing it or stapling it together, could glue it together with fibrin glue.
Okay.
So we thought, great, we'll order some fibrin glue, we'll add it to our bone graft material and make it all sticky like a sausage, and it's going to hold together better. We couldn't order it. The FDA said, well, that is blood that's from 600 or 1,000 donors all in a big vat because commercially made. And so if there's disease from one, it's going to be in all of that whole batch.
Contaminate, yeah.
So we're not going to allow it in the U.S. because the U.S. FDA is much stricter than is the rest of the world. And so we said, wow, we can't do that. So we were going to make our own sort of fibrin glue. In the operating room, and these are large cases, and so in the operating room, we took the patient's own blood, spun it ourselves, let the red blood cells migrate to the bottom, the serum to the top, and the middle layer is concentrated fibrin. And we took that middle layer from the patient themselves and added to our bone graft and made it sticky.
And I mean, So you guys were the originators of this.
Yeah. And what happened is it made it sticky, great for handling. That's all we were looking for. So we stumbled on this. What we noticed is the bone grafts where we use this, the bones seem to be twice as dense and mature twice as fast. Now that's something beyond just stickiness.
That's huge.
So then we started looking into it, realized that middle layer when we're trying to get the fiber in is we're also, because the platelets have the same weight and we're capturing platelets. So if you take a 10 ml test tube, spin it, and take all the platelets in 10 mLs and shrink it down to 1 ml, the same volume, we got 10 times the platelet concentration in 1 ml. And the platelets have growth factors in them, which makes sense. You get a tooth extraction or a broken arm or a paper cut on your hand. What's the first thing that has to happen? Stop the bleeding. What Mother Nature has cleverly done, or divine intervention, whatever you believe in, is the first cell to arrive at the site of injury is the platelets to stop the bleeding. What's the second thing that has to happen in that paper cut or tooth extraction or broken arm? Start the repair process. What Mother Nature's cleverly done is put the things that are needed for that second aspect in the same cell, the platelet. It then releases growth factors and starts the repair process. And since we'd increased the platelets by tenfold, there's more growth factors being released, 10 times as many. And that's what was accounting for double the bone density and double the speed of maturation. And then we termed it at that time. At the first, we actually gave fiber in the star billing. And later we realized as important as fibrin is, the star billing goes to the platelets and has the platelet-rich plasma. And so we started using for bone grafting. And then, of course, you can imagine, for bone grafting, who are the guys that do bone? Orthopedic surgery. So it took off in orthopedic surgery. And from orthopedic surgery to sports medicine. Because, you get a football player, a basketball player, you pay him $10, $50, $100 million. And they're out for the season, you're paying him money to sit on the bench. And you don't get his awards. And so now if they can inject in the PRP, allow the body to heal, at least for the minor injuries, is he's not on the bench, he's playing, the team is getting their money's worth, and they're going on and getting their trophies. Yeah. And so it took off in sports medicine. And then and from sports medicine, it took off into veterinary medicine. Veterinary medicine, the racehorses, the same thing, the expensive racehorses, is you can't have them get injured and not be able to race, or at least to go to a stud farm. You need them, you can't just put them to sleep. And so able to inject. And then it took off from there to open heart surgery today. The complication rate for open heart surgery is decreased by 80% by spraying PRP in the wound closure. And then it went from there to diabetic ulcers, patients that have diabetic ulcers that don't heal for a year, using all types of creams, putting PRP on there within a month, getting healing on. And then it went from there is Juvederm and Restylane, injecting it, to injecting in PRP. It's got to be a specialized form then, because if you put the liquid in, it's going to squirt right back out. And so a specialized form of PRP is, and now it is a $40 billion a year industry. We had nothing to patent because it's Mother Nature. So there's nothing to patent on it. So we don't hold any patents on or anything. We have all the publications on it from those days. Yeah. And we held numerous symposiums. We started we first presented it in 1995 at a bone symposium in Palm Beach. And I just happened to find the brochure on that. We started doing a 3-day symposium dedicated to PRP in 2002, and just did the 18th year of it this year. As 3 days on just PRP. And now in the dental space in the US, there are 40 different centrifuge companies for PRP.
For just dental alone?
For just dental. In the medical space, over 200, I just call them spinners instead of centrifuge, 200 spinners for PRP. When I go to the anti-aging meetings and such, usually I find 30, 40 exhibitors with spinners there. Not all 200 that are in the space are exhibiting there. Usually 30, 40 at one meeting. Wow. Now, what each one will try to do in order to say their machine is better, their spinner is better, say ours doesn't make PRP, ours makes PRGF, ours makes PRC, PRD, PRE, PRF. You will get some of that. And so you get a little bit of alphabet soup these days. But it's always that middle layer.
Okay. Yeah. Stem cells and exosomes when it comes to dentistry. I've got a hypothesis on some of that, and that's actually how I got introduced to you on last minute because I was interviewing
Yeah.
Duncan Ross on the exosomes and trying to think through that. And so I can see why you would kind of cross over on that.
The stem cells is higher concentration than the PRP can give you.
So it has that potential.
Oh, absolutely. And a much, much higher concentration. Okay. So stem cells is the next level up.
Yeah.
Okay. And you say, well, if this next level up, is there still any use for the PRP? I use both.
Yeah.
I use both in combination because the value then at PRP still is the handleability, which the stem cells alone, the liquid doesn't give.
Like liquid.
And the other thing is, it's got all the growth factors in it.
It's more of a wide gamut.
Yes.
Yeah.
It's like this would be taking a lot of vitamin C, the stem cells. Great. That will do a lot. Okay. But you don't need just a bunch of megadose of vitamin C. You also need the multivitamins.
That's right.
So the PRP gives the multivitamin. Okay. That would be the analogy.
That's a great analogy. Well done.
Thank
you. Dr. Garg, I really appreciate it. I know we've probably gone over time. I know we have, not probably, but this really has been fascinating, and I hope that our viewers out there, I know they will walk away with something on this. And so again, I want to say thank you for this time, and thank you for the book. And I am going to actually read it, you know, because I do want to know how we can help. You know, I've learned that I'm kind of that filter between, okay, all the clinical, I'll get that, and then how do I translate that to the public? So for you to do that for the dentists and the doctors out there on this, I commend you, and I thank you, but really appreciate your time.
Hey, thank you so much.
Thank you.